Bom, boa noite a todos. Como nós temos um programa extenso, eu vou imediatamente abrir a primeira sessão ordinária relativa ao 196º ano acadêmico. Por favor, Genilson, abra as portas e vamos começar a nossa sessão. Como nós temos um programa extenso hoje, eu gostaria de ser bem rápida nos avisos. Primeiro, dizer o quanto eu estou feliz de recomeçar. Temos um ano que eu espero que seja muito bom pela frente. E a primeira coisa que eu gostaria de falar é que nós temos algumas coisas importantes. Existe a possibilidade de uma viagem, de algumas viagens. A primeira delas para a Academia Portuguesa de Medicina. Obviamente que tem vários acadêmicos que têm relações bastante estreitas com Portugal. Há também a possibilidade de uma reunião conjunta com a França, com a Academia Francesa, em setembro, logo no início. Eu vou mandar para todos as datas que eles estão nos propondo e, especificamente, eu gostaria de convidar os acadêmicos a considerarem a possibilidade de irmos a Washington no final na segunda quinzena de outubro. Eu vou saber as datas exatas, mas a academia foi convidada pelo seu presidente, professor Vitor Zal, para uma reunião conjunta e por que é importante a decisão dos acadêmicos? Dependendo das especialidades dos acadêmicos brasileiros que se dispuserem a viajar, ele vai colocar matching para que a gente possa discutir com acadêmicos com especialidades semelhantes nos Estados Unidos, em Washington. E por que em outubro? É porque ele está nos convidando para o aniversário de 56 anos da Academia Americana de Medicina, obviamente com jantar, bailes e políticos e whatever we can think about. Então, eu gostaria muito de saber quais são os acadêmicos que têm interesse em participar. Eu, especificamente, estou interessada. Acho que é importante a nossa academia, a despeito dos problemas políticos e das tempestades e tumultos que temos por aí, que a Academia Nacional de Medicina do Brasil se entendesse com a Academia Americana de Medicina. Só como um breve relato, a Academia Americana de Medicina tem 1.400 vagas por ano e ela aceita não médicos como membros e aceita também estrangeiros como membros. Um dos nossos acadêmicos honorários de Recife é membro da Academia Americana de Medicina e é também da OPAS, o Jarbas Barbosa. Então, eu vou mandar tudo isso direitinho e gostaria que os acadêmicos que se dispuserem a viajar se colocassem a respeito para que a gente pudesse arranjar partners que possam discutir com a gente no dia anterior aos festejos. E agora eu vou passar a palavra ao secretário-geral, que tem alguns acadêmicos que já pediram a palavra.
Senhora Presidente, senhores acadêmicos, prezados convidados, nós temos o acadêmico Gotchal, que pediu a palavra.
Excelentíssima Presidente da Academia Nacional de Medicina, professor Eliete Bouskela, membros da diretoria, acadêmicas e acadêmicos presentes. Eu acredito que todos aqui já tenham ouvido falar em Mário Rigato, e muitos o tenham conhecido pessoalmente. Rigato foi aquele homem cuja palavra, assessorada por um quadro negro e giz, valia mais do que uma equipe inteira de audiovisuais. Foi aquele homem que, cientista rígido, nunca deixou que essa rigidez eclipsasse a sua sensibilidade poética. Um homem que atravessou a vida de gala e borboleta, e, no entanto, foi o mais simples e o mais dedicado dos amigos. Eu convivi com o Rigato por 40 anos, trabalhei junto com ele desde estudante e posso atestar tudo isso. Ele falava em viver 120 anos. Infelizmente, viveu apenas 71. Mas, certamente, nesses 71 anos, ele realizou coisas que um mortal comum não faria em 140. Pois a esposa do Mário Rigato, que é honorária desta academia, a doutora Helena Pitombeira, resolveu editar uma fotobiografia do Rigato. E eu tive a honra de ser convidado para prefaciar esse livro, devido aos laços que nos uniam. Foi feito, então, este livro, Mário Rigato, Vida e Legado de um Professor de Medicina, relatando vários aspectos da sua vida brilhante. E a Helena Pitombeira e a família pediram que eu entregasse um exemplar à Academia Nacional de Medicina para que ficasse à disposição na biblioteca da nossa academia. Coisa que, neste momento, eu faço entregando este livro à nossa presidente. Muito obrigado.
Acadêmico Maurício Yunes Ibrahim.
Senhora Presidente, senhor secretário, hoje, como sabemos, hoje é o Dia Mundial do Rim, celebrado no mundo inteiro, e a Sociedade Brasileira de Nefrologia também tem uma série de eventos, os quais nós incluímos aqui hoje uma atividade. E o presidente da Sociedade Brasileira de Nefrologia, doutor José Neto, me pediu que passasse para o acervo da nossa academia uma medalha da Sociedade Brasileira de Nefrologia, confeccionada pela Casa da Moeda, em celebração do Dia do Nefrologista. Obrigado.
Acadêmico Omar da Rosa Santos.
Muito obrigado. Senhora Presidente, senhor secretário, senhoras e senhores acadêmicos, eu recebi um convite do doutor professor Amilcar Tanuri, que frequentou essa academia durante algum tempo e que lançará no dia 19 de março próximo, no auditório do Colégio Brasileiro de Altos Estudos da UFRJ, sobre a pandemia Covid-19. Muito obrigado.
Senhora Presidente, antes da palavra ao acadêmico Jair de Castro, eu vou pedir licença para comentar que foi feito um soft reboot aqui da academia, uma obra com a coordenação da nossa presidência, e gostaríamos de convidá-los depois para visitar a nova sala da presidência, e todo esse anfiteatro foi devidamente reformado. Chamar a atenção dos senhores para o nosso moto, né, da nossa frase, que fica ali acima, era pintada na parede, agora se encontra com caracteres em metal para a posteridade. Acadêmico Jair de Castro.
Boa noite, senhora Presidente, senhor secretário, colegas confreiras, confrades. Queria comunicar que dia 3 de março é o Dia Mundial da Surdez. Nós temos 460 milhões de pessoas no mundo com perdas importantes da audição, Em 2050, serão 2 bilhões de pessoas, e no Brasil nós temos quase 30 milhões, sendo dessas 2 milhões importantes. Amanhã, dia 14, é o dia da semana, inicia a Semana Mundial dos Distúrbios do Sono, problema que impacta 30% dos adultos com ronco e 10% com apneia obstrutiva do sono, que repercute imensamente na qualidade de vida das pessoas. Envolve inúmeras especialidades, como otorrino, pneumologistas, clínicos, cardiologistas, radiologistas e outros mais. E queria cumprimentar também a senhora presidente e as confreiras pelo dia 8 de março, Dia Internacional da Mulher, onde nós observamos o protagonismo cada vez mais importante da mulher brasileira em todos os segmentos. Muito obrigado.
Senhores acadêmicos, só reforçar o convite para a posse do novo acadêmico Henrique Salvador, amanhã, cadeira 61, às 20 horas, aqui nesse anfiteatro. Acadêmico Marcelo Morales.
Senhora presidente, senhor secretário, senhores acadêmicos, acadêmica, eu só queria informar que a Frente Parlamentar da Pesquisa Biomédica e sua aplicação na saúde fez uma recomendação ao relator do orçamento, o senador Ângelo Coronel, e que aconselha o Senado, através do senador Ângelo Coronel, a aumentar os recursos do CNPq em 700 milhões de reais, porque hoje o CNPq tem 95% do seu orçamento destinado a bolsas. E isso compromete o financiamento da pesquisa. Então, a recomendação da Frente Parlamentar, que tem a Academia Nacional de Medicina, Academia Nacional de Farmácia, a FESB com 27 sociedades, o Grupo Farma Brasil, a Abnutri e a Bequif recomenda esses 700 milhões a mais e mais 1,3 bilhões para as universidades federais e para o ensino superior, incluindo a CAPES. Assina a recomendação, em nome da frente, o presidente da frente, o senador astronauta Marcos Pontes. Obrigado, presidente.
Acadêmico Rubens Belfort.
Muito obrigado, senhora presidente, colegas. Primeiro, queria me desculpar, já conversei com o acadêmico Omar, meu avião atrasou, mas eu não podia, de certa maneira, manifestar também minha alegria da academia ter feito essa homenagem tão justa. Segundo, também, hoje é o Dia Mundial do Glaucoma, agora tem Dia Mundial de tudo, né? Mas é para lembrar, também é o Dia Mundial do Glaucoma, uma causa importantíssima de cegueira. O glaucoma, que sempre foi visto como simplesmente consequência da hipertensão ocular, tem novas dimensões, cada vez ele saiu do nervo óptico para ir para a retina, para as células ganglionares, e agora está cada vez mais na região occipital do cérebro, onde se sabe muito pouco ainda, mas o grande fator de risco continua sendo a pressão, e é uma doença até certo ponto evitável se for tratada na hora adequada. Existe também na área de glaucoma uma desconsideração importante, então é importante lembrar. E por último, mas igualmente eu acho importante, é dar os parabéns à presidente e à diretoria por essa ideia de se juntar com a Academia Americana de Medicina. Por incrível que pareça, alguns muitos sabem já, mas não todos, a Academia Americana de Medicina, muito mais nova que a nossa, usou os nossos estatutos, a nossa ideia, para constituir nos Estados Unidos. Vai ser uma excelente oportunidade. Parabéns.
Eu vou passar a palavra ao acadêmico Riella para nós começarmos o simpósio. Por favor.
Bem, boa noite a todos. Senhora presidente, senhor secretário, acadêmicas e acadêmicos e convidados. Inicialmente, nós gostaríamos mais uma vez de agradecer à direção da academia, que desde 2006 abre um espaço para que nós tenhamos um simpósio celebrando o Dia Mundial do Rim. e também atendendo uma recomendação da presidente atual da academia, de que nós mudássemos o modelo clássico que vinha sendo feito desde 2006, ou seja, um simpósio durante todo o dia, que terminava com essa sessão noturna. E foi sugerido que nós, então, restringíssemos algumas palestras neste horário, de temas mais gerais que interessassem também as pessoas não afeitas à nefrologia. Então, a comissão organizadora, o professor Omar, o professor Suassuna e eu, convidamos 4 nefrologistas que residem no exterior, vão fazer a apresentação online agora, e eu vou passar por inglês. Eles já estão online desde as 18h15, e começando pelo primeiro convidado, is Dr. Richard Glassock. Dr. Richard Glassock is a personal friend. I share some passions in life with him. Besides nephrology, he loves wine and is a good golfer. You know, sometimes he sends me a note saying, you know, I just shoot my age. Dr. Glassock, he is 91 years old and is still active and giving lectures all over the world. So you can see his some of his positions that he had in medicine. He had made some breakthrough discoveries in glomerulonephritis, and he will have 20 minutes to give us a vision, his vision, on how nephrology is going to evolve over the next few years. Richard, are you online?
Yes, I am, and I will put my slides up on the camera right now.
Go ahead. You have the
Yes.
podium is for you.
Okay, I'll get them up on the screen. Let's see, where is the okay, I think. Am I showing on the screen?
Yeah, go ahead.
All right. Well, thank you very much, Miguel, for your very kind introduction and also for the opportunity to join the Brazilian National Academy of Medicine in the celebration of World Kidney Day. It's a great privilege to be among such distinguished colleagues, and I certainly want to extend my appreciation to President Bouskela for organizing and overseeing this presentation. Now, as Dr. Riella has indicated, I will be talking about clinical nephrology from the standpoint of World Kidney Day 2025. And rather than dwelling on the past history, the distinguished past history of clinical nephrology, I have decided to take a more forward look on the subject and discuss clinical nephrology at a crossroads. Now, the discipline of nephrology will reach its 65th anniversary of its founding in Avignon, France in 1960, this year. So we have finally reached maturity, and we have a great historical legacy, and we have a great future ahead of us. But I think it would be timely on World Kidney Day 2025 to try to look a little ahead and see what challenges face the further development of clinical nephrology. In that, I'd like to expand on the origins of this crossroads analogy at the 65th birthday of nephrology as a discipline. From my point of view, there are four major contemporary events that are impacting the future development of clinical nephrology as a discipline. First among these is the very, very rapid evolution of effective and safe therapies for kidney disease. Biologics, small molecules, and even gene and transcription modification are presently being used and will expand in their use in the not too distant future. Second, we now have a large number of impressive diagnostic modalities that will likely transform the approach to individual patients with kidney disease, including molecular genetics, new serologic methods, proteomics, and further advances in imaging. Third, I want to comment on the incorporation of artificial intelligence tools into routine practice, which is already occurring and it's accelerating in its pace. Application of large language learning models and neural networks to the practice of clinical nephrology is a very real prospect. And finally, I'd like to comment about how the discipline of clinical nephrology is undergoing a balkanization by the rapid emergence of new subdisciplines such as onconephrology, interventional nephrology, glomerular disease, transplantation, and many others. Let's dig a little deeper into the diagnostic and prognostic advances. We now have available on a broad global basis whole exon sequencing panels which target specific phenotypic clusters of disease which permit, at reasonable cost, diagnosis on a genetic understanding of many previously mysterious syndromes, including nephrotic syndrome, cystic kidney disease, interstitial nephritis, hypertension, and even fluid electrolyte disorders are susceptible to genetic diagnosis. We now are able to undertake transcriptomic analysis of the expression of genes at the tissue level, including kidney biopsies, which will likely transform how we view individual kidney diseases, and it will likely lead to a marked expansion of the spectrum of kidney diseases. Large-scale genetic testing has now opened up avenues of risk scoring, that is, scoring of the likely prognosis for individual patients in regards to multiple genes. 5, 10, or 20 individual genes together may have additive effects on ultimate prognosis. The urine has always been a tool of diagnosis in kidney disease, but with the advent of proteomics, we now have the capacity to understand patterns of urinary protein excretion and their use in diagnosis. And finally, we can characterize putative autoantigens in immunologic disease to permit the molecular dissection of glomerular disease. Now, for example, there are 30 different subclasses of membranous nephropathy based on the molecular characterization of antigens. Along with this diagnostic revolution, we now have many new therapies: B-cell modulation, complement inhibition, metabolic modulation for diabetic nephropathy, new biologics for hypertension, and inhibitors which act specifically on things like cystic growth in adult polycystic kidney disease, autosomal dominant polycystic kidney disease, and oxalate formation. The question that lies ahead is how will clinical nephrology adapt and incorporate these advances in diagnosis and prognosis and therapy? And in my opinion, the chief issue that will have to be addressed is how can these advances diffuse globally at a reasonable speed among clinical nephrology in high, medium, and low-income regions of the world. We need to address the importance of spreading the word throughout the world so that these advances can be applied to individual patients everywhere. Artificial intelligence is everywhere. This book, written in 2019 by Eric Topol, has had a deep influence on my visions of artificial intelligence. The title, Deep Medicine, is quite appropriate in that artificial intelligence is going to make healthcare a vastly different enterprise. Now, I think all of us know that artificial intelligence is the ability of a computer program to think and learn. It needs huge data sources in order to make it efficient. But once those data sources are assembled in a data storage site, the material stored can be used in an immense variety of ways to create new tools for diagnosis and therapy. But at the present time, although this may not last much longer, artificial intelligence cannot feel emotions, love, hate, or fear. It cannot manifest compassion or exhibit intrinsic morality, or it cannot have a conscience or be self-aware. Once these properties are acquired by artificial intelligence, then the whole game of medicine and, in fact, society as a whole will be transformed. Artificial intelligence is not just one thing, it's many things, many different ways of using data to create optimal pathways for rewards and outcomes, and ways to hierarchically interpret data in a multi-layered, real-life presentation. Narrow artificial intelligence is highly specialized, for example, speech recognition or image recognition, and sooner or later, human-level artificial intelligence will in fact be generated, and then we have the opportunity to create, if we wish to, humanized robots or avatars to study and model diseases. Artificial intelligence is likely to have the greatest impact in clinical nephrology and enhancement of diagnostic pathways and prediction of outcomes, but it will also be applied to analysis of digitized images from kidney biopsy, from CT scans, or from MRI angiograms. In the future, and increasingly at the present, clinical algorithms will be individualized by use of artificial intelligence, and algorithmic approaches to management and diagnosis will coalesce with the phenomenon of precision medicine. Every algorithm will be adapted to the individual patient. In clinical nephrology, rational drug design through artificial intelligence is already having an impact, and I now participate actively in the formulation, execution, and interpretation of randomized clinical trials that include artificial intelligence in their operations. ChatGPT-4, which is one of the most powerful of the recent AI programs, has been shown to be able to diagnose complex clinical cases. The blue range here is the proportion of correct responses from experienced clinical physicians in 38 complex clinical cases. On the right black line is total guess. On the right red line is the performance of GTP4. In this case, GTP4 excelled even the very best of the individual experienced physicians undertaking this study. Indeed, in the field of dialysis, which is one of the major subdisciplines of nephrology, the use of data lakes, assembly of information into a single composite data repository, the mechanical issues, the vital signs, demographic, lab tests, and geomics, compressed into an artificial intelligence algorithm, can be used by clinicians to make dialysis even better than it currently is. So in the not too distant future, general medical AI will shift from narrow focus general medicine, like task-specific reports and prompts on electronic medical records, through much broader application to diagnosis, treatment, and prediction, and eventually it will be applied on a universal basis through all ranges of medical care. This leads to the proposition of disadvantages such as loss of human touch and empathy, perhaps even loss of jobs, but these advantages will be outweighed by improvements in efficiency, decreased workload, and better monitoring of patients. But we must remember that artificial intelligence suffers from the black box problem. We provide inputs in the form of data, images, voice, and omics, and we create outputs in terms of analysis, interpretation, and recognition, but what goes on inside is opaque and non-auditable. And if the input is defective, the outputs will also be defective. So we have a lot to learn with artificial intelligence, but the integration of artificial intelligence into clinical practice, including clinical nephrology, is both inevitable and transformative, and it presents enormous opportunities as well as significant challenges. To conclude, I'd like to make a few comments about what is going on now and what was likely to happen in the future in clinical nephrology, which might be called balkanization, because now clinical nephrology is not just one discipline, it is many disciplines, and new sub-branches have evolved, and the numbers increase each year. Some are becoming so well established, like onconephrology, transplantation nephrology, and interventional nephrology, they even have their own societies, their own journals, and perhaps in the not too distant future, their own pathways towards certification by specialty boards. I would envision that this balkanization process will only increase with time. And the question that must be asked is, what is going to be the impact on the development of growth in these new sub-disciplines on training pathways and clinical practice in nephrology? And what in the long term is going to happen to the general all-purpose subspecialty of nephrology when it breaks apart into all of these sub-disciplines? it will be important to maintain the core expertise, the core excellence of clinical nephrology by continuing to encourage the broad practice of clinical nephrology involving all disciplines. I would expect that undifferentiated training in clinical nephrology, which now is about 1 to 2 years in length, will differentiate into research, group practice, solo practice, additional subdiscipline training, and careers in industry or public health. The use of the teams of healthcare, which involve all of these diverse subspecialties, can be acquired on-site in a group practice model or virtual through a solo practice model. But I think in the end, all practitioners of nephrology will have to participate in some way in a healthcare team approach involving oncology, genetics, critical care, and the like. And these teams will be aided in their efforts to provide excellent care by adjunctive services provided by nursing, physician assistants, dietetics, social services, and very importantly, information technology. I'd like to conclude with a speculation, which I think is relevant to the World Kidney Day logo and its mission, that is to encourage people to know what the function of their kidney is and to screen large populations of patients for the presence of abnormal kidney function or kidney disease. When such broad efforts to improve the awareness of kidney disease, and when these efforts in screening become disseminated generally, what will happen to the practice of clinical nephrology when these millions of people who are now not aware of their kidney disease become a part of the healthcare system? Are we ready to adapt our practices to the influx of new patients identified as having CKD that weren't previously aware? And believe me, the numbers are extremely large, particularly in some places in the world. And of course, the subsidiary question is, will early identification, that is, the true positives in screening, allied with better management tools for delay progression, actually result in a decrease in the overall burden of CKD and ESKD? I think these two questions are vital to be addressed as we move forward into the future of clinical nephrology, and I expect that they will be addressed by other speakers in this symposium. So again, thanks for the opportunity to participate in this series of addresses on the occasion of World Kidney Day. Thank you very much. I'm happy to answer or take any questions that might be.
Yeah, we have a moderator, Professor Suassuna. Thank you for being sharply 20 minutes. Congratulations. Professor Suassuna.
Thank you very much, Dr. Glassock, for this very enlightening presentation. And one thing that sort of comes to my mind is that when I started nephrology, I mean, all the nephrology effort was drawn into end-stage kidney disease. So we had a lot of dialysis and transplantation. We had clinical nephrology in a much more blunt, if I may say, a way of approaching, rather with not a lot of drugs and usually some immunosuppressants that would have a broad effect on the immune system. With these new drugs that are on the horizon and this new nephrology that you very expectantly described to us. What do you think would be the path? I mean, are we going to become office physicians like the rheumatologists or perhaps the oncologists, or we are going the other way, as you have shown us, that we should now abandon the office and start working with teams? I mean, or is there well, is this a process that we start in a way and eventually we would move to this other future that you described?
Well, thank you very much for those very important comments. In my opinion, we are moving in this crossroads fashion towards prevention and early treatment of kidney disease in general, so as to avoid the necessity for use of modalities like dialysis or transplantation to treat patients. Now, of course, it's going to take decades or even a century to achieve the eventual conquering of kidney disease such that dialysis and transplantation would be eliminated. I don't think that's going to happen in any of our lifetime. However, the practitioners of clinical nephrology, with the new modalities of diagnosis and treatment, are going to be responsible for assuring that patients receive a diagnosis as soon as possible when the disease emerges, and to apply all of the spectrum of treatments that are available. That requires a team approach. It's very difficult for this to occur on the basis of a solo practice. And I think the future will virtually demand that practice is organized around a team multi-specialty approach.
And if I may, another comment on, we now are starting to look at the exome. And at least in our limited experience, we are overwhelmed by the different number of polymorphisms and SNPs pointing to different kidney diseases in this group of patients, either with idiopathic nephrotic syndrome, focal and segmental glomerulosclerosis, and also of CKD of unknown etiology. So, I mean, we are now looking at a panel of 600 genes, and every patient has a different gene. There is a lot of collagen type 4, type 3 mutations that we don't know how to relate to them, but also many different diseases. So how do you think we should begin to advise these patients when we deal with these newfound mutations that are coming to our practice?
Thanks again for your great question. I'll give you my opinion. When you have a disease of certain pathogenetic significance that is detected by genetic testing, you have a pathway of prognosis and therapy that is identified. For example, in Alport syndrome, if you detect it with the genetic techniques that are available, you know what the prognosis is going to be. And based on early data, in the not too distant future, you may be able to select choices of treatment for individual patients based on their genetic mutation. Unfortunately, at the present level of genetic diagnosis, we get a lot of variation in the genes of uncertain significance. No pathogenesis involved. Those variations may be important, but we don't know how to use them. Artificial intelligence is going to enter this field in a very big way and transform how we use genetic data to determine diagnosis and prognosis. And one of the things I mentioned, polygenic risk scoring, is on the verge of becoming a clinically useful test for determining outcome in individual patients, looking at multiple genes and their interactions. So I think the field is ripe for progress, and with artificial intelligence, I think progress is going to occur very rapidly.
Thank you very much, Dr. Klex. I'll pass the mic back to Mike Riella.
Okay, we're going to move on. I'd like first to invite Professor Maurício Yunes to take a seat here. He's going to be the moderator of the next talk. And if I can have the first slide on Professor Bernard Cano. Bernard Cano is from Paris, originally from Montpellier, where he developed his early scientific career. And he's a good friend of ours, has been many times here in Brazil. And he has published extensively lately on the new techniques of hemodialysis and how this could improve survival. Bernard, are you here?
Yeah, good evening. So I'm here, I'm connected.
You're welcome.
So, thank you very much for the kind introduction. I would share my screen. Let me know if you see my screen. It's okay? Could you see my screen?
Yeah, we see it. Go ahead.
Okay, so thank you very much, Miguel, for this kind introduction, and thank you for this invitation, particularly for President Bouskela and dear colleagues, dear friends. It's my pleasure to share some innovation in dialysis, but the idea of this innovation is, of course, try to transform the patient care for the future. So what I will cover in a few 20 minutes is first, to identify why innovation is really needed in hemodialysis to do something different. And already, as it was shown by Professor Glassock, what are the challenges and limitations of current, I would say, kidney care and particularly dialysis, technological innovation in dialysis. Also, we have to consider some elements which are redefining treatment schedule and setting for the end-stage kidney disease patient, and particularly I will insist on digital transformation and future perspective. So the first topic is, of course, looking at innovation. And that was nicely presented by Professor Glassock. But of course, this is a long pathway because you start with a kidney disease, and then based on the progression of this kidney disease or based on the modification you can do or cure the disease, then you came to end-stage kidney disease, and this is a transition where you move to hemodialysis, PD, kidney transplantation back. But now you're in the state where the patient is a captive of a system. And the only way to get out is, of course, death or maybe cardiac events. So this is quite something we have to consider in the future for the patient. We need to make something different. And of course, when we look now on end-stage kidney disease by dialysis treatment, the point is, of course, we need to change a little bit the philosophy. So transitioning from a life-sustaining therapy to a patient-centered approach. And this is what was presented again by Professor Glassock in dialysis too. Also, we need to align the treatment with the quality of life, in quality goals, and personalized care strategy. So it's not the point just to make survival. The point is to identify what we can do. And also, we need to address clinical, economic, environmental challenges, and emphasizing what is called value-based care. And that should be kept in mind to understand what we want to go. Now, again, to understand what is the complexity, we have to realize that the patient outcome in dialysis is not just based on the technical aspect of hemodialysis. We need to consider the patient profile, comorbid condition, age, and so on and so on. We need to consider practice patterns, and we know from the DOPS, for example, that's a tremendous factors to improve or to modify the outcome of the patient, and also some other factors, and I will take example of these new factors who can be considered to improve the patient outcome. So this is one aspect. Now, what are the challenges and the limitations today? So the point is, of course, what are the unmet medical needs in kidney replacement therapy, and why we need to get tremendous demand. First, we know that the patient outcome remains suboptimal. This is all study from DOPS, but did not really change over the time. So the mortality, depending where you're living, is about 15 to 20% per year, which is tremendously high. Patient perception of dialysis is very poor. It's even worse as compared to end-stage kidney disease before dialysis. Healthcare burden is significant. I don't want to go into cost. It was mentioned about CKD epidemic, still growing, and the cost is between 2 to 3% of healthcare expenditure by the country. Medical knowledge is tremendously progressing. We consider that it doubles every 12 months. So that means we need to consider these factors. And also the patient profile has completely changed. Now treating a dialysis patient is not treating just a kidney disease, but this is treating a complex patient with so many comorbid conditions. Another point, as I mentioned, patient management has changed completely. So dialysis is just not a step in the way of treating the patient. We have to consider all these elements in the futures. Sustainability of dialysis is increasingly question for the water consumption, electricity, waste production, and everything. And also now we have to identify the massive data management of hemodialysis patients. This is a challenge to make sure at the end we can collect this information and streamline the way of using. So based on this element, technical innovation in dialysis. So depending where you are living, but still in the dialysis machine, the baseline or basic features are summarized on this slide. Of course, I don't want to go into detail, the safety monitoring, disinfections, sterilizing, filtration, and online mode of filtration coming to the US, which is very popular in Europe, blood flow, and so many factors. So this is the basic features of hemodialysis. Necessary, but not really, I would say, very exciting. What is coming now is, of course, advanced hemodialysis machine provide much more for the physician and the caregiver. One side is to control the quality of the efficiency based on the recirculation of vascular access performance, the dialysis dose, automated we say control of different functionality, alignment of dialysate to blood flow, and so on and so on, and the tolerance. And of course, on this side, you get blood volume change, monitoring, feedback control, thermal balance control, and which shows some element about the sodium management of the patient, which are very important to prevent cardiovascular mortality. This is the second level. And the third level, and this is coming, is of course health system or the digitalization of the system. Since all the dialysis machines get connected to the internet, so you can get access to this information, and of course you can provide such information to electronic medical record. You have way to integrate all these elements. You have to way to make telemedicine, telemonitoring, quality assurance, supporting the decision making for the physician. So this is a way where certainly we will get much more to learn. Just a few examples. One is, of course, the hemodialysis filtration. So it's not really popular in US, it's just starting, but in Europe it's almost 30 years we have developed this technology. And it has been shown last years that if you provide the right dosage, you can reduce mortality by 23%. So the same treatment time, same parameters, but just providing much more efficient techniques, then you can reduce all-cause mortality. This has been confirmed by the latest, I would say, individual patient data meta-analysis, collecting more than 4,000 patients, confirming that hemodialysis filtration reduce all-cause mortality, cardiovascular, and particularly cardiac mortality by 23, 22%, 17%. So it's confirmed that providing high convective dose is beneficial for the patient. Now, as I mentioned, on the dialysis machine, you get so many tools who can make a measurement about the efficiency. So I don't want to go into detail, but depending where you are, you can use conductivity or UV absorptiometry method to make measurement directly on the dialysate side. And then if you use such a tool, which is almost free for the user, and that was shown in this Spanish study. So they make measurement every session by the KT or KT over V based on these unique dialysates. And the target is to achieve at least 49 liters or 50 liters of urea clearances. So that means KT over V minimum is 1, 2. But you see, if you increase this KT over V up to 55, 60, 60-40 liters, you reduce tremendously the mortality. So this is a way, just monitoring what you are doing on a daily basis or every other day, you can improve tremendously the efficiency, you can reduce mortality, you can reduce in the same way hospitalization. The third topic is, of course, we know that the fluid management or the fluid balance of dialysis patient is a very delicate task associated with the risk of dialysis-induced systemic stress. It has been shown by the Académico conferences that restoring the volemic condition of the patient is always a complex setting. You are between the hypovolemic condition, the hypervolemic condition. I don't want to go into detail of hypertension, cardiac remodeling on one side, ischemic on the other side. But what we know, it's associated with this fluid imbalance or non-homeostatic condition of dialysis patient. You have what is called dialysis-induced systemic stress, which is a modified factors for the cardiac risk of the dialysis patient, involving so many factors, but we know that we have to act on this element. Now, to act on this element, we have different tools. And this is just a study reported a few years ago by Zoccali, showing that if you make a measurement of the fluid status of the patient by independent multi-frequency bioimpedance, so this is not medical judgment, this is just a machine, almost 50% of the patient get fluid overload, with a fluid overload which is estimated between 2.7 liters. And if you look on the right side of this fluid overload patient, if you don't correct this fluid overload patient and you look 1 year back or later in this patient, you immediately identify the overhydration is increasing the mortality risk by 60%. Interestingly, fluid overload is almost independent. It's an independent risk factor from the blood pressure. So we know that fluid overload is already a tremendous risk factor for the patient that we need to correct. And again, we have different tools. I mentioned this bioimpedance system, and this is a study which was developed in Spain. The selected patient with a fluid overload and hypertensive patient. On the one side, they manage the patient with the support of bioimpedance. And of course, what they did within 2 months, guided by the information of this bioimpedance system, they were able to reduce the fluid overload of the patient, reducing the dry weight of the patient, and by the way, maintaining, I would say, reducing the blood pressure without any hypotension. So that means you can guide the patient in the right direction to prevent, I would say, fluid overload and to prevent fluid depletion. One aspect also is coming with the sodium. And the sodium now, of course, we have different tools in Europe, I don't know in US, but this is part of the, I would say, technology that is embarked on a machine. There is a new tool which is called sodium control. And the sodium control on the machine is a way which I will say managed by algorithm in the machine, which is a way to manage the sodium, the mass of the sodium removed, but also to control the tonicity of the patient. So just to explain what was done, I take this Spanish study where they start, which is a traditional way of managing the patient with a fixed diazide sodium, very high, 139, and then they move 3 weeks with a new setting, and then they end by the last 3 weeks by what they call sodium control. And in that case, the machine is adjusting the diazide sodium to the plasma sodium level of the patient. So there is no more way to fix the sodium, but aligning the diazide sodium to the plasma of your patient. And if you look very impressively, and if you just check the conductivity, of course, phase 3 and phase 4, you see that the conductivity of the machine is reduced to, I would say, lower level, meaning that mostly the patient are dialyzed with too high diazide sodium. And this is an impact, that has an impact on the plasma sodium concentration. If you consider the sodium fixed to 139, you see that the both dialysis sodium is 139, meaning that you keep the patient very high, certainly acting on the thirst of the patient, while if you make isotopic condition, then you put the patient back to the same plasma sodium level So you maintain the isotonicity of the patient. And what is the result? Of course, the diazate machine is reduced. You reduce post-dialysis sodium concentration. You maintain the sodium mass balance, but you don't have any more diffusive sodium, I would say, removal. You reduce the SIRS, you reduce weight gain, and you reduce intradiabetic mobility. So this is a way, just to explain, you can act on the sodium. Another interesting point is, of course, what is called patient-reported outcomes. So this is a subjective assessment of the patient to understand what is a patient perception. And in this setting, the PROMISE, which is a self-reported healthcare interactive with adaptive questionnaire, which are made by computerized adaptive testing. You need to get, I would say, computerized system, you need to get a tablet, you need to get this algorithm. But that was a PROMISE, which was part of the CONVINCE study I mentioned already. So the questionnaire was developed and was tested in a patient for three years. So it's not anymore the SF36, which is performed once a year. This is a questionnaire with the support of tablet and electronic digital system, which was administered every 3 months to the patient. And what was the discovery? First, if you analyze, I don't want to go into detail, but the physical functionality, cognitive function, sleep disorder, and so on, you see that, and fertility, in the next 3 years, there is a decline of almost all these parameters. But still, if you look on the blue line, which is reflecting the hemodiafiltration, there is a beneficial effect, and particularly on the cognitive function. So hemodiafiltration as a way to preserve cognitive functionality of the patient. Not only this element, but also to improve the functionality of the patient, social participation, physical activity, and then certainly reducing the burden of the treatment. Now, another point, green dialysis, that we know that water consumption, waste management, this is a question that we have to fix in the future to reduce and to preserve resources. Again, if you look on the hemodiafiltration, this is a way, this is a simulation that we perform based on a CONVINCE study. If you compare the water consumption or the diazate consumption in this case, usually you take with a 4-hour session, almost 120 liters. If you perform what was done in a CONVINCE, 143 liters with a 23 liters. Now, if you perform with smart hemodiafiltration machine, with automated ultrafiltration control, auto-flow system, which is controlling the diazate fluid, you can reduce down to 96 liters. So there is a saving on the water, which is almost 40 liters, while you keep the same efficiency. So we can save a lot of water while we keep the efficiency. So meaning that the machine are certainly, I would say, in a nice way, smart hemodiafiltration machine. Now, certainly also in the future, and this is the way to go, we need to shift our current kidney replacement therapy paradigm, which is one size fits all, 3 times 4 hours or 3.5 hours in US. We need to center on the patient and patient-centered care in order to fix the dialysis modality, location, prescription, patient-reported outcome, patient management, to make sure at the end, this is a multi-dimensional scale to make sure that we fit with the patient. Okay? So there is different way to act. One is a location, one on the intensity, one on the modality, and one fitting with the patient profile. I will not go into detail, but just to show that we have option to make sure that the treatment can fit with the patient. Now, again, new technology based on this smart portable device can provide support for the patient for home treatment. So I don't want to go into detail, but certainly what is good in this new technology, this is the digital support that you can provide to the patient. Certainly you can provide all this information, you can have a patient connected, you can control the efficiency, you can control the tolerance of the dialysis. Another point is, of course, in some countries, the concept of incremental dialysis, and certainly the hemodiafiltration is a nice way to preserve the kidney function. This is coming from the UK, where they show that using large-scale hemodiafiltration, you can preserve the kidney function up to 4-5 years. So that means if you implement correctly in some countries this incremental dialysis program, you have a way to preserve the kidney function, as the PD is doing. I did not talk about more intensive dialysis with the nocturnal, but you can do. And the last point from my side is, of course, digital. And certainly, as it was mentioned by Professor Glassock, if you combine artificial intelligence, the big data management, all this ICT system and advanced analytics, then this is the way to collect all this information to make sure at the end you capture this information, make analysis, and provide a tremendous support for the patient, but also for the physician to make sure you can adjust the treatment in the right way. I just selected few elements. AI. If you look at the impact of AI on the anemia management, and this is a true study which was performed through 4 countries, so not in one center, more than 400 patients. So just collecting information every month using the support of artificial intelligence to define what is easy dosage, iron dosage, and suggestion. What it has been shown, you have, based on this element, this anemia control module, and to support the clinical decision, you put the patient, you increase tremendously the patient numbers in target. So in that case, the target was 10 to 12 grams. So you increase by 37% the patient in target. Not only, but also you reduce tremendously the fluctuation. So that means at the end, there is no more fluctuation, what we know could affect the outcome of the patient. So there is a way to streamline and reduce fluctuation of the hemoglobin. But not only, you reduce the consumption of ESA by 50%. So could you imagine what you can do if you apply that to the large population of dialysis patients in US? 50% less erythropoietin consumption, okay? Another point, this is a clinical implementation of quality improvement. So nothing changed except this is based on the analysis of the data and the KPI, to just analyze KPI, you can check. It's not very complex, KTOVV, vascular access, fluid status, and just continuous quality improvement with a medical patient review. So that means every month there is a discussion. And if you look after 3 months, almost all parameters improve. So that means just by sensitizing the physician and the caregivers, providing the numbers, you provide a way to improve the care of the patient. And if you do that, you reduce mortality, and particularly you reduce mortality and hospitalization in diabetics and non-diabetic patients. So just improving the care. And the last point, which came a few months and has been confirmed by different studies, if you get access to large data set of patients using machine learning, a prediction model, you can anticipate the intradialytic hypotension. So in that case, 16% of intradialytic hypotension. The study shows that you can anticipate by 15 minutes the occurrence of the hypotension. So that means there is a way to prevent such element. And the last point, which is my favorite one, we know that the patients are not dying in a dialysis center, they just die home. And if we want to make this type of support, we need to monitor the patient, at least patient at risk, with the different tools. And different tools connected to cloud computing, but this is based on pervasive monitoring tools without any complexity for the patient. It's already done with so many factors. You can monitor the hemodynamic, monitoring, arrhythmia, fluid status, vascular stiffness. All the tools are already existing, even sleep disorder. So this is a way to make sure at the end you can identify patient at risk. And this is an integration where the contemporary treatment is, I would say, one size fits all. And this is the way where we have to go with a very personalized treatment and certainly precision dialysis, as it was mentioned a few minutes ago for the precision medicine. So based on this element, what is the take-home message? Innovation in kidney care is critical to improve the clinical outcome and the patient experience, and also ensuring the long-term healthcare sustainability, because we need to save the money. Currently, the hemodiafiltration outperforms conventional hemodialysis, and should be widely adopted to maximize the patient benefits. Personalized and flexible treatment schedule are essential. I show this incremental, more intensive, nocturnal, whatever. This is a way to make sure that at the end you can reduce treatment burden and enhance the quality of life for the patient. And again, cutting-edge technology, AI, pervasive remote monitoring are set to revolutionize the dialysis care, optimizing the treatment, providing this precision dialysis and patient management. And certainly the future of dialysis depends on this precision medicine, sustainability, and patient empowerment driving for better outcome and certainly to transform the care delivery. Improving long-term outcome for end-stage kidney disease require optimizing the patient trajectory, and this is what I mentioned. It's not only just the way the end of the road where it dies, we need to integrate all the treatments that we are able to provide to the patient and certainly make the best for the patient to identify the risk, to identify certainly the best treatment for each patient. So with that, I just want to thank you for your attention and happy to take any question if you have any question. Thank you very much.
Thank you, Bernard. Thank you very much. Professor Yunus is here as moderator, and he's going to conduct a couple of questions or comments.
Thank you very much, Professor Cano. Are you seeing? Yeah? Are you hearing?
Yeah.
Yes. Hi. Thank you very much for this outstanding presentation. Et merci beaucoup vis-à-vis le décalage horaire. Vous êtes très...
Exact. It's almost midnight.
Un grand effort pour être avec nous dans la journée mondiale de l'Iran. Bien. Since Claude Bernard in 19th century, we know that we need to have an interior medium in the good conditions. We started in 20th centuries, we started by the end, from the kidney failure, and we needed to save lives, our nephrologists. How to do this? Using diffusion or convection from small to higher molecular size. Technology applied to nephrology, as you showed us, we had a big evolution in 50 years. And how do you think for the future, the challenge on environment and the cost for offer dialysis treatment for mondial population?
That's a good question. I would say it's a little bit more complex because it's not only saving the life. The point is to address this cost issue. But of course, I'm thinking about this dialysis in a Western country, which is already, I would say, nicely implemented. And certainly we made tremendous progresses, as you mentioned, from the quality of this membrane, from the quality of the water, from the quality of everything, for the management of the patient. So we made tremendous progresses, but one limitation of the efficiency and certainly the tolerance of dialysis is the treatment time. And certainly if we want to make more efficient, if we want to reduce more or if we want to improve the survival of the patient, certainly we have to revise this treatment time and frequency. This is one aspect for Western part of the planet. Now, if we consider different part of the planet where the resources are limited, I'm sure that, again, we need to provide, I would say, different way of addressing this kidney replacement therapy, maybe starting with a certainly low-cost dialysis or starting by PD or implementing different technology. But I know, for example, closely related to India or different, I would say, Asia and Pacific places, dialysis is already developed with a lot of, I would say, difficulty, but already developed with, I would say, some limited technology. And certainly the most constraint is the cost. If you consider that, for example, in India, they pay just $30 or $40 for the dialysis session, could you imagine that in Europe or US? That would be almost impossible. So they develop, I would say, different, I would say, model and healthcare system where they can implement dialysis. But again, if we look on a projection, and the projection said that maybe within 5 or 10 years, depending on this efficiency of the new medication or drugs, it's expected to get 6 million of patients with end-stage kidney disease to be treated in dialysis. That would be a tremendous burden. I don't know how we can face such element, but certainly we have to consider different way of treating the patient. Hopefully, maybe the medication will cover or will cure most of the disease, but still, if you look on the different, I would say, projection about these numbers of patients coming to dialysis, this is still increasing almost every year, and particularly with the most fragile patient, elderly, with a comorbid patient, with a lot of complexity. So it's not anymore to treat a patient by any form of dialysis, but certainly to consider this support of all this functionality which are, I would say, affected in this country. So depending on the region or country, you have to consider different perspective in a way of treating patients.
Thank you very much. Unfortunately, we are on time. I will pass to Dr. HORIZONTES.
Thank you.
Thank you, Bernard. Appreciate your collaboration here. We have to move on. And I'm going to turn the microphone to Professor Suassuna to introduce my dear friend Adira Levin from Vancouver. And I'll also ask the moderator, Professor Josemir Lugon, to take a seat here at the table.
Thank you very much, Miguel. It's my pleasure to present Professor Adira Levin. She's a major driving force of nephrology worldwide, and she's been involved in a number of initiatives from the point of view of epidemiology, clinical research, fostering the specialty of nephrology in many different parts of the world. She's a professor of medicine, head of nephrology at the University of British Columbia, and it's, as you all see, a superb speaker. Are you with us, Adira? Can you?
I am, thank you. And thank you for that very kind introduction. Can everybody hear me okay? Just a thumbs up would be great. Okay, so these are my disclosure and perspectives. And my topic that I was given was chronic kidney disease, but I added to it and said, what could I possibly say in 2025 on World Kidney Day about new perspectives, treatments, and hope? And so in the next 20 minutes, I hope to go through this with you and make sure that this audience is aware that about chronic kidney disease as a global health problem, that there are new tools and approaches to diagnosis and treatments, as alluded to by our other previous speakers, and of the updated guidelines that will hopefully stimulate discussion amongst this audience, but also when you go home. So this is a lovely overview put together a couple of years ago now, describing chronic kidney disease as a global health problem, and especially drawing our attention to the fact that by 2040, kidney disease will be the 5th leading cause of death in the world, that there are groups of people more likely to have a diagnosis of kidney disease, and that it's a large burden in all countries around the world, especially in low and middle income countries. There's a high unmet clinical need. There are estimates of about 850 million people worldwide having some form of kidney disease, whether that's acute or chronic. And as many of you know, acute often leads to chronic. And that, as Dr. Kennard said, that about 5 to 10 million people die each year because of cardiovascular disease or inability to actually access dialysis. And in developed countries, there are huge costs associated with both non-dialysis and dialysis care. And I think these are things that help us when we're talking to policymakers. And I think we're not necessarily as good as we should be at identifying high risk and early disease, which is far less costly than even preventing progression of kidney disease and its attendant cardiovascular disease, which again is much less costly than the dialysis or transplantation. And I think it behooves us to think about how best we can do this. It is an exciting time in the kidney space. We have so many new tools for diagnosis and risk stratification. We're really going towards precision medicine. The current evidence to delay and prevent is growing, and we understand better the cardiac, metabolic, and kidney interactions, and there are new paradigms of care and implementation science to help guide us. We have learned a lot, and whilst there's a lot of issues around some of the definitions, there is a value to consistency of definitions, collaborating, improving our clinical research paradigms, and including participation, and all of this ultimately culminates in improved outcomes for patients. There's new data, new hope, and new questions, and I think on this day of World Kidney Day, it's nice to reflect on each of these: diagnostics, prognostics, and new therapies. So whilst the classification and definition has always included cause, we often have not been, we've been a bit lazy as nephrologists in terms of trying to find this cause. And I think it's important for all of us to increase our appreciation of how we must figure out why someone has kidney disease, and we can't just assume it's hypertension or diabetes. We're learning that through the value of biopsies, which give us not only better diagnostics, but in the context of other research and educational collaborations in systems biology, understanding mechanisms of disease. And then as we increase our sophistication of techniques and learnings and can deep phenotype people, understand genetics, and now are better at assessing tubular function and renal reserve, we really are getting somewhere different. We have better imaging that informs care. And if you look at this, the new burgeoning multiparametric MRIs to help us understand kidney physiology, we can appreciate oxygenation, microstructure, and hemodynamics in a way that we hadn't been able to before, which should give us insights and help catch kidney up to where cardiac is now. There are increasingly sophisticated heat maps using age and eGFR, creatinine, cystatin C measurements, and I will draw your attention not to the details of this, but rather that a combination of ACR and eGFR using a more precise, if you will, estimation using two components is actually remarkably good at predicting 6 cardiovascular, 2 kidney specific, and 2 general outcomes in a large cohort of patients. And I think this gives us pause and helps us to communicate with our non-nephrology colleagues. And with that increased sophistication and number of prediction tools, we can now look at validated tools that help us with kidney donation, declining in eGFR, kidney failure risk equations, and actually even cardiovascular disease risk prediction, adding on to current scores or actually generated net new. And by connecting these risk equations and thresholds to actions, that actually helps physicians as well as patients understand where they're going and increases our sophistication. And of course, this is all being tested in clinical care to optimize intake. We, in the new guidelines, actually remind everybody that the heat map is just a generic high population, but we really need to assess individual risk based on their cause, specific demographics, and a number of other conditions. And so we actually advocate for calculating the absolute risk of adverse outcomes on an individual level, which needs the risk prediction equations, not the heat map. And this is just an example of some recommended thresholds based on kidney failure risk equation and what one might do in terms of transitioning from primary to team-based care to access and transplant planning as an example. Now, we've all had a long-standing recognition of cardiovascular and kidney disease patients, and this just describes here the cardiovascular disease mortality risk across CKD categories, and reminding us that relative to a general population of males or females, if you're on dialysis compared to the general population, your risk is exponentially higher, which is very sobering. And we know the reason for this is a complex physiology of cardiac and vascular, and on purpose there, I've written diseases, because none of this is a single entity, and the complexity of the cardiac kidney phenotype needs to be appreciated by all of us and truly understand the differences over time and within and between individuals. We know that over time, there's an interconnectivity of cardiovascular, kidney, and metabolic conditions, and it's becoming, not only they are interconnected, but they amplify the risks and the costs, that the natural progression is the accrual of all of these risks, culminating in a fair amount of morbidity towards the state of kidney failure. But these new paradigms and models for risk prediction might actually help us to predict and maybe intervene. And there are these novel prediction equations for absolute risk assessment of cardiovascular events in patients with kidney disease, which is really important. It's called the PREVENT equation, and I think we haven't necessarily socialized this use in clinical practice. But given the changing prevalence of risk factors and care patterns and new models, I think it's important that we not stick to the old Framingham risk, for example. And by improving our prediction, we can better tailor treatment plans, make sure the right people are getting the right therapies, also improve our ability to talk to patients and counsel them, and then the timeliness of decision-making. And ultimately, we can also better design clinical trials by targeting populations and specific phenotypes, as well as processes and outcomes. In 2017, I had the privilege of leading a very diverse and eclectic and incredibly smart group of people while we deliberated how we would close the gaps in care, research, and policy. And part of that was not just improving identification and understanding causes, but really developing and testing new therapeutic strategies. And so for the remainder of this talk, I thought I could talk about the changing landscape in nephrology, which has gone from really not that much to a whole plethora of very rich and exciting times. And this is a slide many of you have seen in both the diabetic kidney disease world and the non-diabetic world, that, you know, up until about 2002 or 6, we really didn't have we had very little from 2006 forward. But in the last 7 to 10 years, there's been a huge number of different trials with a number of different agents, which has made life very exciting and much more hope for our patients. I couldn't give this talk without highlighting the SGLT2 inhibitor trials and remind us that they started in 2015 with the observation in the EMPA-REG outcome study, which was for diabetics and glucose control, that it was important to look at kidney outcomes. And over time, a number of different studies, both kidney and cardiac related or diabetic related, have evolved, culminating in a really excellent paper, which I hope all of you have looked at in the Lancet, which is an individual level meta-analysis of all the large RCTs of SGLT2s across people with and without diabetes, cardiovascular and kidney disease, all of whom had measures of GFR and urine ACR, and who had a concordance of their outcome measures. In 90,000 people across 13 trials along a range of GFRs and a range of median follow-up, and 18% of whom were not diabetics, what you have is a consistent signal, irrespective of diabetes, sex, or age, of the value of SGLT2s in delaying kidney disease progression, in alleviating acute kidney injury, which in many places is a driver of CKD, and importantly, attenuating cardiovascular death or hospitalization for heart failure. And I think these are powerful data that help us to really talk to patients. And this is just a schematic of what this would mean, even when you start early at a mean decline of about 4.6 mils per minute per year. If you take some of the data and just flip the average decline in the treatment groups, you gain 15 years of life in an average patient that was in the trials that started with an age of 63 and a GFR of 56. And of course, this effect is seen throughout the spectrum and is even more perverse at lower levels of kidney function. We also appreciate that after SGLT2s, we've really begun to understand the role of other hormones and pathways in disease progression, which has been very exciting. And we've looked at several new drug classes that are in clinical development for the treatment of kidney disease, the GLP-1s and the aldosterone synthase inhibitors, which I will call ASIs because it's a mouthful, the non-steroidal MRAs, and the endothelin receptor antagonists. And I think it's important for us to look at what the current indications are and what some of the data shows. I hope that this audience is well aware that GLP-1 receptor agonists have a series of kidney protective effects in patients with kidney disease and diabetes. They inhibit oxidative stress, inflammation, fibrosis, and they induce a natriuresis. And whilst we've known for a while about 3-point MACE and A1C improved reductions in albuminuria and weight loss, the important thing for us to also remember about these drugs is that you do not need a dose adjustment for low GFRs or those on dialysis. And the FLOW study, which was really exciting and presented last year at the ERA, demonstrated that for the entire composite, for the primary outcome, which includes a composite of a first kidney disease event, GFR slope, cardiovascular disease, and death, semaglutide was effective in reducing all of these outcomes in people with diabetes and kidney disease. I use those words carefully because not everybody had diabetic kidney disease. They had diabetes and they had proteinuria. So that's important. SELECT shows the same things in overweight individuals without diabetes who already had cardiovascular disease, and again shows an improvement in outcomes with semaglutide. Again, very exciting in the current world. When one turns to aldosterone synthase inhibitors that reduce aldosterone exposure and mitigate all the harmful effects of aldosterone excess that we all learned about even in medical school, I think it's exciting to think about the anti-inflammatory, the antioxidative stress, the improvement in endothelial function and reduction in fibrosis that can be looked at. And these are under investigation now in the context of SGLT2 inhibitors in a number of different trials with a number of different compounds on the back of promising phase 2A and B studies. The non-steroidal MRAs also prevent activation of pro-inflammatory and pro-fibrotic pathways, and these are another new group to add into our armamentarium. You will remember the Fidelio, which is the combination of, the Fidelity study, which is the combination of Fidelio and Figaro, which basically are mirror image studies of themselves, of each other, with with opposite primary and secondary endpoints, but defined the same way. 14,000 people with a clear signal in people with diabetes and kidney disease, given meeting inclusion criteria and given this non-steroidal MRA, significant reduction in the important outcomes. And this was actually interesting because they were able to actually have almost 800 people who were also on SGLT2s and found that all of these was upheld even in the presence of an SGLT2, or irrespective, if you will, irrespective of which the outcome was. And there are a number of other indications now and studies underway looking at finerenone outside proteinuric diabetic kidney disease. And you've already heard recently the outcomes of the Fine Arts heart failure study, and we're awaiting some of the other ones to look and see whether in non-diabetics and those without cardiac disease, whether or not we'll be able to use this agent. And last but not least, in terms of endothelin receptor antagonists, there are a number of, they also have similar important effects like lowering blood pressure, reducing inflammation, fibrosis, proteinuria, and restoring podocyte function, which is actually an important and critical component of kidney functions. So these potential future treatments are holistic, and they address multiple cardiovascular, kidney, and metabolic conditions in parallel. Which combination one uses, how and when, is really one of the challenges. And if I think about where all this leaves us with care, guidelines, and research, it's important that if you haven't read the 2024 guidelines, I would encourage the audience to do so. And remember that kidney disease is not a disease of old people. It actually starts in many people in perinatally or in early childhood. And we really do need to take a much more holistic lifespan approach that includes sex and gender. We're now aware that there are very different effects of some of these drugs and adverse effects in men versus women at different ages in the life cycle, and our ability to implement this into clinical practice is going to be very important. Chapter 3 of the guideline is all about delaying progression and managing its complications. And I don't have time to go through all of it, but I think importantly, this is the first time, and Dr. Riella will remember that when we wrote this guideline almost 10 years ago, we were unable to have a lot of high-level evidence for delaying CKD progression or its complications, but we're really happy to be able to now articulate a very important and pillared approach to treat chronic kidney disease. This slide actually demonstrates where we're at in the diabetic world in people with kidney disease and how each of these different drugs works. But importantly, in the context of non-diabetic kidney disease or people without diabetes and with kidney disease of anything, we're looking more and more at how we might implement the non-steroidals and all of the other new agents as they become available on a base of lifestyle modifications and the other sensible ways to manage all chronic conditions. So I want to conclude by saying that there remain some ongoing tensions between these inclusive frameworks and goal-directed management and precision medicine. How do we time this? How do we individualize it? How do we identify phenotypes within the classification systems? Should everybody get a GLP-1 even if they're lean? Maybe not. If you don't have diabetes, what is your age and sex, and how should we implement this? Everything, everywhere, all at once, or in a stepwise fashion? And how do we actually, really interrogate the information that we have, building new clinical trials and new data? So what I've tried to do in the last 20 minutes is just give you an overview of the new tools, new treatments, and new hope that is evident in kidney diseases. There's better diagnostics that inform all sorts of aspects. There's new drugs with solid evidence, and there are ongoing trials with new agents and repurposed agents that will actually help us delay progression. And so again, I'd be happy to answer any questions on this World Kidney Day, and especially call out the fact that this is all about detecting early and protecting kidney health. So I thank you again for the invitation and happy to answer any questions.
Thank you very much, Adira. Well, now our commentator is Professor José Lugon, and I'll just pass the mic to him.
Okay, at first, I'd like to thank the organizers for offering me the opportunity to be here and listen to this outstanding conference. Very much updated, addressing a very relevant topic. Due to time, I'm just gonna ask one question to Dr. Levan. In the list of medication that you have enrolled, do you see any role for intestinal binding, potassium binding agents in the management of CKD, consider that many of the drugs that were aligned may cause potassium retention, especially in people that have chronic kidney disease?
Yeah, no, it's a really interesting question, and I think it's one that comes up a lot. So yes, there's a role for potassium binders. I will tell you that when we look carefully, it's about 25% of an entire non-dialysis population that truly has sustained hyperkalemia in a danger range. That's number one. Number two, that often it's transient and not necessarily related to the drugs that they're on. However, recognizing that people get nervous with the higher levels of potassium, I think that the potassium binders are of value because they especially allow us to not stop the drugs that are good for the patients. And I think that that's an important consideration. I will say that as nephrologists, we probably need to educate people more that a potassium of 5.2 is not a critically high value and does not necessarily need intervention. But I think that's very much a personal thing, and many people sort of just err on the side of ultra conservatism in terms of keeping potassiums under 5. But it's a good question, and yes, there's a role. I think that with good diet, diet hygiene, hydration, the true incidence of sustained dangerous hyperkalemia is much lower than many of us think.
Okay, thank you.
Thank you very much, Adira. Thank you for the very enlightening presentation. And we now just move on to our final presenter tonight, Professor Leonardo Riella. I don't think he needs any introduction for this audience. Can I just have his biography slide, if I may? The slide is late. I don't think Leo need any introduction, so just carry on. Leonardo, are you there?
Obrigado.
Agora
Boa noite a todos.
Vamos voltar para o português, que eu acho que a nossa audiência agora ficou toda na nossa língua mater. Ah, tá aí o slide de biografia. Obrigado, Léo. Pode continuar, por favor.
Obrigado. Eu vou só colocar meus slides aqui. Muito obrigado mais uma vez pelo convite. Ele está participando no Dia Mundial do Rim 2025 e está dividindo aí um pouquinho. Vocês estão vendo o full screen agora?
Sim, sim.
Ok, maravilha. E ver esse desenvolvimento, essas inovações que ocorreram dentro da nefrologia e como realmente está mudando o aspecto da nossa especialidade e a gente espera que realmente continue a atrair novos residentes e especialistas para fazer essa especialidade em específico. O meu objetivo nos próximos 20 minutos é falar um pouquinho do futuro do transplante renal. E é interessante ver que, né, a nefrologia começou mais ou menos no mesmo momento que o primeiro transplante de rim com sucesso ocorreu em 1954, aqui em Boston, no Peter Van Brigham, em que foi transplantado um rim entre dois irmãos gêmeos idênticos. Desde então, o que a gente observou dentro do transplante foi uma evolução enorme em termos de sobrevida do paciente. Então, esses são dados agora de 2025, em que resumem qual é a média de sobrevida em 3 anos dos pacientes transplantados nos Estados Unidos. A gente tem o nosso programa aqui como referência em azul, que deu uma sobrevida de 91% em 3 anos, e a média nacional em torno de 87%. Mostrando realmente que o transplante de rim é um procedimento com grande sucesso a curto prazo. Mas existem 2 dificuldades e 2 barreiras enormes no transplante para que ele se torne um tratamento mais difundido. O primeiro é a barreira imunológica. Então, com gêmeos idênticos, não se precisa de imunossupressão, mas se você está fazendo um rim entre indivíduos geneticamente diferentes, vai ter uma resposta imune e vai precisar de imunossupressão. E o segundo é a questão da escassez de órgãos. Então, como vocês podem observar, o tratamento principal da insuficiência renal terminal atualmente é a diálise. Nos Estados Unidos tem mais de 650 mil pacientes em diálise, enquanto que anualmente a gente faz somente em torno de 28 mil transplantes. Então, vocês veem que, na verdade, a diálise se tornou o tratamento permanente a longo prazo da maioria dos pacientes com insuficiência renal crônica. E aí que a gente vai falar um pouquinho das inovações e como é que a gente consegue reduzir essa escassez e dar ao paciente o melhor tratamento no caso da doença renal terminal. Começando pela barreira imunológica, a grande dificuldade dos nossos pacientes, na verdade, é a imunossupressão a longo prazo. Porque essa imunossupressão, além de enfraquecer o sistema imune, causar um aumento de risco de infecção e certos cânceres, ela vem associada com uma série de outros efeitos colaterais, muitos deles metabólicos, por exemplo, um risco bem aumentado de diabetes, osteoporose, mas também hipertensão, toxicidade do rim, neurotoxicidade e hipercolesterolemia. Então, todos esses riscos adicionais da imunossupressão, na verdade, acabam afetando a qualidade de vida do paciente e diminuindo a sobrevida dos pacientes transplantados. E eu acho que uma das grandes evoluções que a gente tem observado dentro da imunologia foi entender que o sistema imune, sendo o nosso exército, na verdade, ele não é formado só de soldados, não é formado só de componentes de efetores que fazem a defesa, mas, na verdade, o sistema imune é formado também de uma série de células e uma série de componentes que regulam esse sistema imune. E toda a imunossupressão que se desenvolve, que vem sido usada no caso do transplante, não tinha nenhuma noção da presença desse sistema de imunorregulação. Então, a grande importância disso é que, se a gente entender a importância desse sistema de imunorregulação e como ele funciona, a gente poderia daí utilizar o nosso próprio sistema imune para controlar e evitar que ocorra a rejeição. E a gente tem evidências muito claras da importância dessa imunorregulação só na manutenção da tolerância ao nosso próprio corpo. Então, nós temos todas células autorreativas no corpo, células imunes que reagiriam a partes do nosso organismo, causando doenças autoimunes, mas nós não temos doenças autoimunes, na maioria dos casos, pela presença desses sistemas de regulação do sistema imune. Da mesma forma, toda vez que tem uma infecção, toda vez que tem algum estímulo, esse sistema imune tem que se expandir para regular e tentar eliminar a infecção, mas uma vez que a infecção esteja exterminada, você quer que o sistema imune retraia, forme a memória, mas que não continue sendo ativado. Então, essa regulação do sistema imune evita que hajam vários desses efeitos colaterais ou ativações excessivas do sistema imune que podem levar a consequências muito graves. E a gente sabe muito bem, no caso do Covid, esse é um exemplo claro de como a infecção acaba não matando, mas é a resposta imune exagerada. Então, como a gente observa o futuro do transplante e o uso desse conhecimento para melhorar o manejo desses pacientes? É justamente tentando promover a imunorregulação, tentar promover a expansão desse sistema regulatório do sistema imune, para que, então, a gente não precise usar tanta imunossupressão que enfraquece, então, todo o sistema imune. E existe não uma estratégia, mas existem várias estratégias sendo avançadas nesse sentido. Um deles é entendendo melhor as vias coinibitórias, as vias importantes que regulam o nosso sistema imune, fazendo um pouquinho do oposto em que o tratamento de câncer está fazendo, no sentido de, em vez de remover os freios, remover a sinalização por PD1, por CTL4, você quer, na verdade, aumentar essa sinalização para justamente reeducar o sistema imune. Existe também uma série de estudos avançando com o uso de terapia celular, você expandir as células imunorreguladoras e daí infundir no paciente, algumas vezes até de forma antígeno específica, então específicas para o doador que a gente selecionou. Existem alguns agentes interessantes também que afetam diretamente as células imunorreguladoras, expandindo essas células pela presença de receptores especiais. Eu vou mostrar um dado sobre isso aí, sobre a muteína de interleucina 2. E, por último, existe uma maneira, na verdade, de você tentar reeducar o sistema imune, afetando, na verdade, o timo e a medula óssea, que é através do transplante combinado de rim e de medula óssea, que é um mini transplante de medula óssea. Eu vou falar um pouquinho disso aí com 2 slides. Falando um pouco mais da questão da imunorregulação, uma das células, que talvez seja a célula do sistema imune mais importante para regular o sistema imune, são as células T reguladoras, que são positivas para um fator de transcrição chamado FOXP3. E essas células T reguladoras, CD4, elas são essenciais porque a gente já sabe que mutações, tanto em humanos quanto em camundongos, dessa célula em especial, causam uma série de doenças autoimunes. E a gente sabe também no modelo do transplante, se a gente deletar essas células, se a gente remover essas células, ocorre uma rejeição acelerada. E se a gente aumentar o número dessas células em modelos animais, a gente consegue, na verdade, aumentar a sobrevida do enxerto e minimizar a necessidade de imunossupressão. E o que a gente fez, na verdade, foi tentar entender qual era o acelerador dessa célula T reguladora, qual era a sinalização que era importante para causar com que essa célula se ative e se expande. E parece que uma das principais é, na verdade, esse receptor de interleucina 2 de alta afinidade. E o que a gente desenvolveu foi o seguinte: a gente fez uma droga nova que, na verdade, faz uma sinalização especial nessas células T reguladoras e a gente testou a partir daí em vários modelos animais, camundongos e também em macacos, e a gente mostrou que com uma dose só de imunossupressão peritransplante e a injeção desse medicamento só para expandir as células T reguladoras, a gente conseguia uma sobrevida do camundongo com transplante de coração de 100% a mais de 100 dias, enquanto que o paciente que recebia só imunossupressão acabava rejeitando a maioria dos órgãos. E o mais importante foi que, na verdade, não precisava continuar essa expansão das células T reguladoras por mais de 60 dias. Se você expandisse as células T reguladoras no momento em que os antígenos estão sendo apresentados inicialmente para o sistema imune, você cria, na verdade, uma tolerância que é antígeno específica. Então, se a gente pegar esse camundongo receptor 100 dias depois do transplante e a gente fazer mais um transplante, um segundo transplante com o mesmo doador, a gente não precisa de imunossupressão. Então, isso é uma maneira extremamente interessante de tentar minimizar as drogas imunossupressoras através da expansão do próprio sistema imune regulador. E uma segunda maneira é uma maneira um pouquinho mais, digamos assim, intensa, que seria o transplante de medula óssea e rim combinado, que cria o que a gente chama de quimerismo misto. Como é que ocorre isso aí? Quando você consegue com que células tanto do doador quanto do receptor estejam ao mesmo momento, por exemplo, no órgão do timo, existe uma reeducação do sistema imune que acaba, então, deletando células que sejam reativas ao doador e causam também uma expansão das células T reguladoras. E o timo é a nossa escola dos linfócitos T, então você tem que criar, na verdade, espaço no timo para que essas células, então, entrem e comecem a interagir, e isso leva, então, esse desenvolvimento da tolerância periférica e central. E uma das coisas interessantes sobre esse protocolo é que, na verdade, envolve um regime de condicionamento, que, digamos assim, são umas drogas que vão criar esse espaço no sistema imune. Existe uma radiação que ocorre uma vez no timo para justamente maximizar a aceitação das células do doador, e uma vez no dia zero, então, é feito tanto o transplante de rim quanto o transplante de medula óssea ao mesmo tempo. E dentro de um mês, esses pacientes estão só com uma imunossupressão, tacrolimus, e depois de 12 meses, se a biópsia é normal, a gente para completamente a imunossupressão. Isso mostra, por exemplo, pacientes como essa menina que teve um transplante inicial com 12 anos, por 10 anos teve imunossupressão, tinha uma série de complicações, inclusive verrugas difusas no corpo, e acabou no segundo transplante decidindo fazer um transplante com a medula óssea e já vem agora com mais de 17 anos, sem imunossupressão alguma, mostrando tolerância completa. E o que a gente fez, na verdade, em 2023 foi conseguir criar um centro de transplante de tolerância clínico. E a razão que demorou tanto para começar a se fazer esses protocolos e de uma maneira um pouco mais avançada e com maior número de pacientes é que para pagar a medula óssea é muito caro e o seguro geralmente acaba não pagando. Mas com a criação desse centro, a gente conseguiu, na verdade, dividir, no sentido que o centro paga pelo transplante da medula óssea, enquanto que o seguro paga para o transplante de rim. E desde que a gente inaugurou esse centro, a gente já fez mais de 16 transplantes e os resultados estão ótimos, e na próxima vez eu posso mostrar um pouquinho disso aí. Mas realmente foi aí a diferença de criar esse centro único no mundo só para estudar e desenvolver protocolos de tolerância do transplante. Então, da barreira imunológica, a gente vai passar um pouquinho para a questão de escassez de órgãos. E vocês viram um pouquinho nas palestras anteriores como isso é um problema. E para nós, médicos que fazemos transplante, o que a gente observa é que, por exemplo, nos Estados Unidos, 17 pacientes morrem diariamente enquanto eles estão na lista de espera, esperando subir até o topo da lista. E claro que, no caso do transplante de rim, o que determina a posição na lista, na verdade, é quanto tempo eles foram inscritos nessa lista. Então, não tem nada a ver com a questão de quão doentes eles estão. E isso é um grande problema, porque nos Estados Unidos tem mais de 100 mil pacientes esperando transplante e a gente só faz em torno de 25, 28 mil transplantes por ano. Então, esse gap aqui continua aumentando, e claro que esse número ainda é muito maior, que tem 650 mil pacientes em diálise, mas muitos deles nunca chegam à lista de espera. E a razão que não chegam é porque cada momento que eles ficam em diálise, cada tempo, cada mês, ano que se acumula em diálise, o risco, na verdade, de complicações aumenta exponencialmente. E como foi mostrada na última palestra, o risco cardiovascular é o principal. E a gente sabe que o risco de mortalidade no paciente em diálise chega a ser 6 vezes maior do que no transplante, sem falar em todo o impacto da diálise na qualidade de vida do paciente. Então, uma vez que o paciente chegue a essa insuficiência renal terminal, o tratamento ideal é, o mais rápido possível, a gente tentar transplantar esse paciente, desde que ele esteja condições de saúde para passar por uma cirurgia. O xenotransplante, na verdade, vem com essa ideia de, então, revolucionar um pouco essa escassez, essa gap enorme dos pacientes que estão esperando o rim e da ausência do rim de uma maneira ajustada em termos de tempo. E o xenotransplante envolve, então, o transplante de um rim de porcos geneticamente editados, especificamente o que a gente vai falar. E a vantagem dos porcos é uma principal, eles têm uma reprodução extremamente eficaz, então a gestação é em torno de 3 meses e meio, geralmente leva a mais ou menos 6 a 12 filhotes por gestação, e em 1 ano a gente já pode usar o porco para o transplante. Então, na verdade, isso aí leva a uma possibilidade de você escalonar essa produção de uma forma extremamente eficaz. E a gente já usa, na verdade, válvulas cardíacas e outras coisas na medicina que vem do porco. Claro que existem desafios em você transplantar um órgão completo. Inclusive, algumas incompatibilidades imunológicas que foram sido descobertas nos últimos 40 anos, assim como algumas variações fisiológicas que, na verdade, quando a gente separou dos porcos 80 milhões de anos atrás, isso levou a algumas alterações. Mas, por último, existe na questão de regulamentação digamos, um perigo assim em questão de doenças infecciosas sendo transmitidas do porco para o humano. Mas vamos falar um pouquinho só desse risco imunológico. Se a gente pegar um rim de porco, um rim selvagem de porco e transplantar num macaco, nos primeiros minutos a perfusão é perfeita, o rim pega uma coloração muito boa, mas em 5 minutos isso que ocorre. Ocorre uma coagulação completa e uma hiperrejeição desse órgão. Então, isso foi se observado por muitos anos e, claro, com toda a pesquisa feita pelos cientistas que vêm trabalhando com xenotransplante, a grande virada que levou finalmente a gente conversar sobre xenotransplante como sendo uma potencial realidade foi a adaptação da CRISPR-Cas, os nossos instrumentos para editar o gene, para o xenotransplante, porque se sabia quais eram os órgãos, os genes, quais eram as proteínas que a gente tinha incompatibilidade, e através do uso dessa tecnologia, a gente pode daí, então, ir editar o gene de uma forma extremamente eficaz, precisa, e realizar mais de uma alteração ao mesmo tempo. Então, a gente chama um pouquinho de tesouras mágicas nesse sentido. Levou ao Prêmio Nobel em 2020, mas a tecnologia em si foi descoberta em 2012 e, a partir daí, já começou tem sido estudada nos porcos e no xenotransplante em particular. Então, eu vou falar um pouquinho da nossa experiência com o xenotransplante. A gente usou um porco que é de uma raça que chama Yucatán. Ele é um mini porco e a gente realizou alterações genéticas nesse porco, principalmente a remoção de alguns açúcares, 3 carboidratos principais. A gente realizou a inativação de alguns vírus que chamam-se retroviruses, endogenous retroviruses, que são, na verdade, vírus endógenos presentes no DNA. E isso é importante para tentar minimizar esse risco de infecção. E alguns genes foram adicionados num cassete para tentar realmente regular tanto a via de complemento quanto a via de coagulação e tentar suprimir alguns dos sinais importantes de inflamação. Então, esse foi o porco geneticamente editado que a gente realizou o primeiro transplante de rim em humanos. E esse foi umas imagens da gente fazendo a retirada do rim do porco um centro de pesquisa, mais ou menos 1 hora de Boston. Então, vocês podem ver aqui mais ou menos o rim in situ e depois aqui sendo trabalhado ex vivo. Esse rim, então, daí foi transportado até o Mass General e a cirurgia demorou em torno de 4 horas. A grande dificuldade foi, na verdade, a doença vascular avançada do paciente que a gente selecionou. O paciente que a gente selecionou tinha 60 anos, tinha mais ou menos 8 anos em diálise, tinha perdido um transplante prévio e ele tinha uma calcificação vascular bem extensa, além de doença cardiovascular. Mas depois de 4 horas de cirurgia, a gente pode observar aqui à esquerda que o rim tomou uma cor muito boa e em alguns minutos a gente já conseguiu observar no ureter a produção de urina. E nas primeiras 24 horas teve alguns litros de urina já sendo produzidos. Então, esses foram já sinais iniciais muito bons que realmente o rim estava funcionando bem. Aqui um pouquinho da curva da creatinina. Creatinina é o nosso marcador principal para medir função renal. Vocês podem observar que ela caiu bem na primeira semana, ele teve um processo de rejeição celular, mais ou menos em torno do dia 8, foi tratado e a creatinina, então, nivelou a partir daí. E, como vocês podem observar, nesse gráfico, o potássio se permaneceu estável, nenhum potássio acima de 5,5, nenhum potássio abaixo de 3,5. Outros eletrólitos e outros balanços que são importantes, como o sódio, também a gente pode observar que não houve hipernatremia, não houve hiponatremia. Então, o rim, na verdade, funcionou de uma forma assim, extremamente eficaz em manter todo o balanço de mineral e de eletrólitos no corpo. E é claro que, para os pacientes com insuficiência renal crônica, dos pacientes em diálise, isso apareceu realmente como sendo uma esperança muito grande, né? E realmente tomou uma magnitude assim muito maior do que a gente poderia esperar inicialmente. Claro que o grande herói em toda a história é o paciente, né? Porque o paciente realmente ele aceitou fazer um procedimento em que existiam riscos, digamos assim, desconhecidos, né? É muito fácil a gente falar dos riscos que a gente sabe, mas em um procedimento como esse existiam muitos riscos que eram realmente desconhecidos. Ele, no dia 20 pós-transplante, ele já não teve diálise no pós-operatório, todos os eletrólitos se mantiveram estáveis, estava com uma boa diurese e ele foi para casa com uma creatinina de 1,7. Mais ou menos, acho que 2, 3 semanas atrás, a gente finalmente publicou o caso no New England Journal of Medicine, então tem todos os detalhes ali, são quase 25 figuras suplementares mostrando todo o curso que ocorreu com esse paciente. E o infeliz acontecimento foi que, depois de 52 dias, a gente viu ele na clínica de manhã, ele estava bem, estava só dizendo que não tinha se hidratado muito bem na noite anterior, a creatinina estava um pouquinho mais alta, a gente hidratou, deu um pouquinho de magnésio para ele, mas na mesma noite que a gente viu ele na clínica, ele não começou a se sentir bem em casa, acabou inicialmente esperando, não fazendo nada, e, por final, ele acabou tendo uma arritmia e acabou falecendo. Uma das coisas que a gente descobriu na autópsia, realmente, que a doença cardiovascular dele, em principal do coração, era uma doença extremamente avançada. Vocês podem ver do lado esquerdo, né, a hipertrofia cardíaca que ele tinha, um coração quase 2 vezes o tamanho normal. E não só isso, apesar, né, de todos os exames que a gente faz pré-operatórios e tudo, é muito difícil a gente quantificar a quantidade de cicatriz nesses corações. E a gente sabe que a doença microvascular, na verdade, é uma das consequências principais da diálise e da insuficiência renal crônica. Então, a gente pode observar, principalmente na coloração por trichroma, que é a direita, o quanto de cicatriz ele tinha no coração. Mas não teve nenhuma evidência de um infarto agudo do miocárdio, não teve embolismo pulmonar, infecção ou inflamações que a gente conseguisse observar aqui. E o rim, a gente fez na autópsia a análise do rim e não tinha nenhuma evidência de rejeição ou qualquer alteração. Então, realmente foi triste esse final, mas a gente conseguiu a aprovação do FDA para fazer mais 3 pacientes. E a grande diferença agora é que o FDA permitiu que a gente selecionasse pacientes que não tivessem um caso tão avançado de doença cardiovascular, que não tivessem realmente nas suas linhas terminais em termos de acesso vascular e outras coisas. Então, a gente acabou realizando em janeiro de 25, então mais ou menos 2 meses atrás, o nosso segundo xenotransplante. Esse é o rim que a gente transplantou, de 170 gramas. O receptor tinha 90 quilos, era um paciente diabético, mas ele tinha apenas 2 anos em diálise. Foi uma cirurgia bem mais simples, em 2 horas a gente conseguiu fazer o transplante. Pode ver aqui o rim também com uma coloração muito boa, e teve também uma diurese fantástica nas primeiras 24 horas. A creatinina desse paciente era muito melhor ainda do que a creatinina do paciente passado, em parte porque ele não tinha tanto a doença cardiovascular do outro paciente. Vocês podem observar que a creatinina é em torno de 7, 8, e ela baixou em torno, abaixo de mais ou menos em 1 aqui, teve um pequeno aumento aqui e acabou nivelando. Então, eu vi o paciente ontem, ele está dia 47 pós-transplante, ele está com uma creatinina de 0,9 e uma filtração glomerular de 94 ml por minuto. Então, realmente, a gente não podia esperar por um resultado melhor até agora. A gente tem mais 2 cirurgias planejadas para 2025, então a gente vai realizar isso aí provavelmente nos próximos meses, e isso aí vai abrir, então, o caminho para estudos clínicos ainda maiores. Então, acho que no xenotransplante, diferente talvez de um desenvolvimento de droga, o avanço tem que ser um pouquinho mais espaçado, porque a gente aprende muito com cada caso, e isso nos ajuda a tentar ajustar um pouco, por exemplo, a seleção do nosso paciente, a imunossupressão e assim por diante. Então, aqui à esquerda, esse paciente foi para casa já 7 dias pós o transplante, e aqui a foto de ontem, quando ele veio na nossa clínica fazer um acompanhamento. Então, ele continua fazendo exames de sangue 3 vezes por semana e vindo nos ver na clínica pelo menos 2 vezes por semana. Então, o que eu quis mostrar é que o xenotransplante realmente tem o potencial de diminuir essa escassez de órgãos a longo prazo. A gente mostrou que ele é capaz de manter a função renal, manter os eletrólitos e, mais importante, eu não mostrei, mas não teve nenhuma evidência de transmissão de infecções do porco para os humanos. A gente teve um episódio de rejeição celular aguda no primeiro paciente, como eu mostrei, mas o que a gente observou é que o mesmo tratamento que a gente usa para tratar a rejeição celular em humanos funcionou muito bem no caso do paciente que a gente transplantou. E o mais importante de tudo, claro, é a seleção do paciente. Então, a gente acredita que para pacientes que realmente têm pouco tempo em diálise, não têm um doador vivo e têm uma perspectiva de ganhar um rim só 5, 6 anos em diante, esses seriam os pacientes ideais para a gente tentar fazer esse transplante, para que seja realmente uma ponte até eles mais ou menos chegar mais para o topo para receberem um rim humano. Claro que teve um time enorme que fez parte disso aí, não vou ter tempo para nomear todos, e claro, teve a indústria, uma série de indústrias, inclusive a Genesis, que, claro, nos proveu o órgão, mas também outras empresas farmacêuticas que nos deram algumas drogas que ainda não são aprovadas para serem usadas no transplante renal. Então, eu paro aqui e, mais uma vez, muito obrigado pelo convite, e estou à disposição aí para qualquer pergunta. Obrigado.
Pois é, não, estou recebendo aqui um aviso do Miguel. Não, primeiro para agradecer o Léo, assim, cada vez que eu vejo a apresentação dele, ele traz sempre mais novidades, né, um entusiasmo aí do avanço da ciência do transplante. Só fazer uma pergunta, qual é a sua visão? Assim, você mostrou várias estratégias diferentes para endereçar o problema da falta de órgãos e da rejeição. E você terminou agora dizendo que talvez a transplantação com porco seja um pouco mais à frente. De tudo que você mostrou, qual é o teu cronograma aí, em termos do que a gente vai poder aplicar na clínica com sucesso?
Eu acho que as terapias de expansão do sistema imunorregulatório vão ser terapias que vão estar sendo estudadas nos próximos anos, e a gente espera realmente que vão mudar aquela nossa estratégia da imunossupressão tripla, que já vem há mais ou menos quase mais de 40 anos sendo utilizadas. Então, eu acho que essa parte aí realmente vai se desenvolver nos próximos anos. É claro que a gente vai ter que testar, né, em diferentes grupos de pacientes, em diferentes condições, mas tem um grande potencial realmente de minimizar essas drogas imunossupressoras. O transplante de tolerância, que envolve a medula óssea, é ainda um transplante que talvez seja mais voltado para pacientes mais jovens, por envolver uma indução um pouco mais intensa, por envolver realmente um tratamento um pouco mais intensivo do que a gente observa num transplante normal de rim vivo. E, claro, acho que o xenotransplante ele tem muito potencial. Vai devagar, esses próximos passos vão ser devagares, mas eu acho que a gente tem um potencial realmente de tentar mudar essa perspectiva e trazer um novo tratamento, uma nova opção para esses pacientes com insuficiência renal terminal, espero nos próximos 3, 4 anos.
Muito obrigado, Léo. Muito obrigado pela sua participação. Eu passo a palavra, então, para a nossa presidente para encerrar o simpósio.
Olha, dado ao avançado da hora, eu acho que a única coisa que eu posso dizer é boa noite a todos e muito obrigado por terem estado conosco.